Right, good evening, everyone. We're just going to give everybody a minute to get signed in. All right, okay, we're going to start 4 minutes after 8. So welcome to ACHQC Core Insights, November edition. This month, we're going to talk about adjunctive measures to loss of domain hernias. Our moderator for the evening is Dr. Anthony Iacco. He's a hernia surgeon at Beaumont Health in Royal Oak, Michigan. Our education is going to be done by Dr. Kelsi Swanson. She's a chief at UT Southwestern. And our cases are going to be presented by Dr. Sam Zolin, who's a chief at Cleveland Clinic. So if you want to share your screen, Kelsi, just start. For any questions, you can post them in the chat, and we'll take a quick break after the first presentation to answer any questions, and then again at the end.
Nobody came, sorry. Okay, should I start?
Yeah, go for it.
Okay, so as Megan said, we're going to talk about some adjunctive measures to loss of domain in hernias. So in general, why do we care about loss of domain? What is it? So it's when you have herniated contents that permanently reside outside of the abdomen in the hernia sac. And so basically you have a second abdominal cavity. It makes repairs more complex. You have risks postoperatively of respiratory failure, and that's in about 8 to 11% of patients, and also circulatory compromise due to the compartment syndrome. And then our goals here basically with the adjunctive measures, we're trying to prevent the intra-abdominal pressure from rising faster than the patient's physiology can adapt to. And then our goal with the hernia repair itself is to have a tension-free primary fascial closure. So not only do we not want compartment syndrome, we want a long-lasting hernia repair. So the first article that I'm going to talk about is progressive pneumoperitoneum and how it's used. In this article, they talk about hernia sac volume to abdominal cavity volume, and it's calculated based off of a CT scan. The hernia sac and the abdomen are ellipses, and so you can see from the diagrams that if you get the hernia sac volume and the abdominal cavity volume and then divide them by each other, you'll have a volume ratio. And in different studies, it's not quite agreed upon what would constitute loss of domain. Some studies say less than 25%, you should be okay, but this can help you plan your hernia repair. So in the progressive pneumoperitoneum, that study that was just up there, they looked at incisional hernias larger than 10 centimeters of loss of domain. They included ones with greater than 25%. They used a permanent catheter prior to surgery to implant it away from the hernia site. So silicone catheter. Like I said, they calculated the hernia sac volume. What they did in this was they did progressive insufflation with increasing increments of 500 cc's of CO2 daily. So on average, it was about 8 days. And then they wanted to insufflate the abdomen to the hernia sac volume that they had previously calculated, so that would help them get to their endpoint. Then they used an onlay polypropylene mesh and fixed it with Vicryl, and they placed a drain in all of their patients. So they did this in 23 patients. The mean volume was 36% volume ratio. 4 to 8 days preoperatively was how many days that they had to do daily insufflation. Of these patients, they had 6 wound infections and 1 recurrence at 2 years. They had 2 deaths. Post-op day 1, they had an MI, and then they had someone that had a death post-op 1 year with pneumonia. The majority of these patients were females. They were in their 50s, and almost everyone was obese in the study. And then you can see the hernia sac volumes were on average about 450 cc's. And then about 10 sessions was what was needed. The next one I'm going to talk about is Botox botulinum toxin A. So this works, everyone knows how this works, but I'll go over it again. So it inhibits presynaptic cholinergic nerve terminals. This does lead to defunctionalization of the muscle groups that it's impacted, but it's temporary. The thing that's important about this is it can lead to elongation of the muscles and some atrophy as well. But with this, you get increased abdominal wall compliance, and then you can also see decrease in the hernia size during the treatment. And then it's most effective between 3 to 6 weeks. Some say 3 weeks, or some say 4 to 6 weeks post-injection. But you'll see in the next study or article that some people injected prior to surgery and some people injected right at surgery itself. So this is chemical component separation, concepts, evidence, and outcomes. This was a literature review. It included 6 articles. The mean hernia size was 11 to 17 centimeters in transverse dimension. They either injected 3 regions bilaterally with a total of 200 to 300 units of Botox, or they did 5 regions bilaterally for a total of 500 units. And it would kind of vary in where they would inject, if they would do it intramuscularly or around the fascia, and how deep, and it's dependent on each study. But they also always did it under image guidance. So these patients that ended up getting Botox, they cited fascial closure rates of 40.9 to 100%, but the majority of them completely had fascial closure. The one that's 40.9% was the patients that they actually injected the Botox on the day they operated on the patient. So they didn't have the preoperative weeks of prior treatment. And most of these patients required component separation as well. Another thing that this can do is it can help improve postoperative pain. So then the next study that talks about Botox preoperatively is a study of 220 patients, and 75 of them with Botox injections. As a 2-to-1 propensity scored matching, and they looked at just preoperatively what the hernia sac volume to the abdominal volume was, and so they said that if it's greater than 0.5 or at 0.5, it indicates a third of the viscera is within the hernia sac, and then if the ratio is 1, then half of the viscera is within the hernia and half of it's in the abdominal compartment. So in these patients, they injected 1 month preoperatively into the lateral abdominal wall muscles. They did it at 6 sites with anywhere between 200 and 300 units. So when you look at this, some of the things are quite interesting, where they had primary fascial closure in the Botox patients, 92% of them, versus 81% of them of non-Botox patients. And that was statistically significant. The recurrence for the follow-up on average was 14 months, but 9% of the Botox patient had a recurrence, and then at 29 months, 12% of the non-Botox had a recurrence. But they also had higher classes of wound, CDC wound classification in the Botox group, but lower surgical site infection rates. Some of the things that were also noted was there were more smokers in the Botox group. There were more component separation in the Botox group as well. They had, like I said, high fascial closure, used more biologic mesh, and they did more delayed primary closure of skin and subcutaneous tissue with the Botox They noted that people were more likely to have an ongoing infection at the time of hernia repair, though, in the Botox group. That's why they ended up using biologic meds and delayed primary closure. So adverse events that you can have with Botox. So it said that there weren't any really related to the injections themselves, but some people did notice that they had some abdominal bloating or a weak cough, but this was resolved after repair. But there are certain people that are not going to be candidates for Botox. People who use aminoglycosides, if you have impaired neuromuscular transmission or pre-existing paresis. So, myasthenia gravis or any issues, they're not going to be candidates. So you have to carefully think about these before. And then in patients with COPD, it can be a relative contraindication because you're basically defunctionalizing some of the muscles that are going to help these patients that need a little extra help breathing. You're going to defunctionalize those muscles. So next, we're going to talk about tissue expanders. The same tissue expanders that plastic surgeons use regularly. So this is a review of 14 articles. Every patient had to have a 2-stage hernia repair with tissue expanders. The defect size ranged from 77 to 2,400 square centimeters. They looked at 103 patients. 86 of these had hernias that had been skin grafted previously. 12 of these patients had tissue expanders placed prior to transplant, and then 5 of these patients had congenital abdominal wall defects. So this study actually included children, unlike some of the other studies. In most of the patients, they had subcutaneous insertion of their tissue expanders, and that was so that they could have increased skin coverage. Between internal and external oblique. 2 were posterior to the rectus, and 1 was intraperitoneal. So the ways that they decided to place these tissue expanders were they made it lateral to the defect in non-scarred areas. And if they were going to do it intramuscularly, they did a transverse incision, or they did it one of 2 ways. They did a transverse incision inferior to the costal margin, and that was about a 5-centimeter incision, or they did it midway between the costal margin and the ASIS and inserted their tissue expanders there. This is beneficial in these patients with skin grafted hernias because it recruits skin with increased vascularity, and so you can have better coverage of your hernia there. They say in this study that it's mostly should be used for large acquired ventral hernias, someone with a previous skin graft or recurrent hernias. It's good for people with attenuated fascial layers, congenital malformations, intra-abdominal transplants, or they've even used it in separation of conjoined twins when they need to enhance whatever tissue might be there. They noted that you can also use these, even though it's a foreign body, with a stoma. They're recommending that you make the incision away from the stoma, which makes sense, and then only have the tissue expander in for a short interval. And they didn't have any infections in the patients that actually had the stoma in this review. But the complications with the tissue expanders are always there. 11 patients had infections, either a cellulitis or an abscess. 8 had a hematoma. 3 had a rupture. 3 had an extrusion. Urinary retention, dehiscence, and puncture during expansion and port issues all happened in 1 patient. And this required 6 patients or 6 expanders to be removed after stage 1. And then in stage 2, the risks, obviously the hernia repair, these make sense. They're pretty typical. Recurrence happened in 12 patients. There were 6 with skin necrosis. 2 patients died, 1 of sepsis and 1 with an MI. So then we are going to get to component separations. So in anterior components, this is kind of written about first. You divide the posterior rectus sheath and separate the rectus from it. And this gives you different amounts of length depending on where you are in the abdomen. So the upper, middle, or lower abdomen, you get about 3 centimeters in the upper, 5 centimeters in the mid abdomen, and 3 centimeters in the lower abdomen. And that's per side. And if you still have some tension there and you need to increase how much you have in your release, you can then go to the external oblique and you can release that as well. You want to make sure that you're cranial to the rib cage and inferior to the pubic symphysis. And this will get you about 5 centimeters, 10 centimeters, or 3 centimeters. And so you get up to about 10 centimeters of midline advancement per side. And then of note, you want to be very careful in these patients to preserve their perforating vessels. This decreases wound complications, so you don't get skin necrosis, infections. So this is something that you have to be extra mindful of during the anterior components. So talk about the Reeves stopa because it's a transition into the posterior. Basically what this is you do a retromuscular dissection and then a sublay of mesh posterior to the rectus. The mesh can extend about 6 to 8 centimeters to either side of midline, and then you're inhibited by this linea semilunaris as you go laterally. So if you need wider coverage because of a large hernia, that's what's going to push you to a posterior component. So it can be inadequate for large hernias. So for posterior components, you want tension-free closure of the posterior rectus sheath. Something that's beneficial of this is you avoid lipocutaneous flaps like you do in the anterior components. You don't have quite as much space, and so it can be beneficial there, less seroma, hematoma. Something you have to be very careful of, though, is de-innervation to the rectus abdominis. If that happens, it can be pretty devastating for the patient. And so you do your transversus abdominis release. You do retromuscular space posterior to the rectus abdominis, and then you do the incision of the fascia media semilunaris, and then division of the transversus abdominis, and then the sublay mesh would be the basic steps for that. So here have an article about the release in the upper right hand corner, just have a picture of basically what the final product looks like. So this is a retrospective study of 42 patients, and 10 of those patients had wound complications, so 24%. Only 2 had recurrence, so it's 4.7%. And it was on average 8 to 12 centimeters of advancement per side. And then the average mesh size was 1,200 centimeters squared. So by doing a transversus abdominis release, you do extend how much mesh coverage you can have, and it's not in the peritoneal space, so that's also beneficial. You do want to be very careful about not violating the peritoneum or the fascia, though. That can be pretty detrimental to the repair depending on where it is and how big it is. Small ones you can sometimes use over. So.
Awesome. Okay, thank you very much. Dr. Iacco, do you have any comments to make?
Absolutely. I mean, I hope that we have 18 participants. I hope you guys can make some comments here on the chat or raise your hand. And we can call on, I see there's some faculty on here too. So you presented like 6 huge topics in 20 minutes. So we should just pick a couple things and talk about those. I'm not sure what the group wants to discuss, but I certainly think Botox is this hot topic. Tissue expanders is a little bit, I think, more concrete, but Botox we could talk about first maybe. Would that be all right? Yeah,
sure.
So the paper that you presented from Henneford's prospective propensity matched trial seems to indicate that Botox may have a small role in increasing fascial advancement. And in most of these patients, something like 85% or so of all patients, both Botox and non-Botox, I think almost all of them achieve primary fascial closure. Is that right?
It was in the 90s for the people with Botox and about in the 80s for the people without Botox, yeah.
So most people got completely closed. It's interesting, you know, I think in my own experience, in our own experience, most patients who do receive Botox were unable to achieve complete fascial closure. So I wonder if many of the patients that he propensity matched for and against us were going to be closed almost always anyway. So it's hard to to know if those patients were properly selected. At least I think patients with 20 centimeter defects, 30 centimeter defects, I wonder if there's any advantage to using Botox in those patients. And those aren't the patients that he looked at, really.
Yeah, I agree with that. The other thing was that the Botox patients were more likely to have a component separation, and then they were more likely to achieve fascial closure. So I don't know, that to me, like, I guess it could say, if you think you're gonna have to give Botox, you're likely gonna need to do a component separation, but you can just do the component separation and still get people closed. So I just don't know what the role of Botox is there.
Yeah, I feel similarly.
Hey, Kelsey, could I ask you a quick question? So that was a great presentation. It's a lot of data, and I agree with Anthony. Like, this stuff, at the end of the day, there's all this information, and we're always left with like, okay, so we're taking care of patients, and like, when should I use it, and when do I not need it, right? Like, that's the clinical question that we're all asking, because it's kind of one of those situations where if you really needed it and you didn't do it, when you're in the operating room, you're gonna regret it. But if you do it on everybody and you don't need it, it's hard to know whether it's helping you or just the standard things that you're doing are helping you. And that kind of gets you. So you just read all this stuff, you put all this stuff together. So tomorrow in clinic, like, describe to me the patient that you would give. Let's start with the easy one. Who would you give Botox to?
I think I would give it to someone, I guess, that, I mean, they would have a large hernia defect, and I think I would really be questioning if I was going to be able to close their defect or not. I think,
Well, let me ask you a question.
yeah,
Actually, let me ask Sam Zolin a question. I'm gonna ping over to Sam. Sam, so Kelsi said she's going to do it when she's afraid she can't close them in the OR, which is, I think that's rational. But how do you figure that out when you have a baseline of almost all these papers are in the high 80s, low 90s of fascial closure, right? So like, who is that patient?
Yeah, so I mean, that's where you mentioned like the Tanaka score, and looking at hernia sac to abdominal cavity volume measurements can really be helpful. And you can, you can sort of do a gross assessment of, the patient that's in front of you, look at their scan, look at how much viscera is. Yeah.
How many times have you been in clinic and you've actually calculated the Tanaka score? Do you have the app or something?
0 times.
0 times. Okay. So that's not really going to be like.
So, yeah. So, I mean, if they, if they have a wide defect, narrow rectus muscles, that's generally going to be the person that you are going to struggle to actually get, anterior fascia together.
And let me ask you this. So you're sitting in the OR, you just spent 5 hours. Like, how do you know whether it's wrong to close somebody? Like, does everybody get, like, what is your strategy in the operating room? And like, when do you say this is too much? Right?
like when to bridge instead.
What's that?
To bridge instead? Like, when would you bridge instead?
Right. So like, this is to me, this is what's really hard about fascial closure, and Megan can probably speak to this. I think everybody has a different threshold for how tight they will close people. It is my perception that certainly mine and many of the folks that I work with every day will close people tighter than most people think is appropriate. And so, Megan, you've been with us now for a couple months. Is it fair to say that, I mean, you came from a major center, a lot of trauma, all that stuff. Do you think that we close people tighter than what you've seen in the past?
I don't know. Yes, I guess. But if we're really worried, we just check a plateau pressure before we start closing. And then if it goes up by greater than 6, like, we have taken a few people to the ICU intubated.
Right, so I think that's kind of one of the key things, and that's one of the things in this articles that I think is interesting and unknown is that's actually kind of the meat of why I think we struggle with the Botox thing. But I'm curious about it because we are willing to close people tighter than many people, but then we accommodate for that by keeping people intubated and letting them reacclimate, and then over a day or two they get better. The question is, in these really big hernias, which most of the Botox data isn't in big hernias, would that avoid increase in plateau pressures, respiratory complications, and allow you to potentially, you were going to close everybody anyways, but you close them with less physiologic consequence. And to me, that's kind of an unknown with Botox that ought to be studied. It's a little subjective because you can measure it with like plateau pressures maybe, but you'd have to have controls and everything. But to me, it's an unstudied aspect, and it's not necessarily like we know. And I think this is where people get kind of off the rails. If you do this enough, you pretty much know that just about everybody can be closed if you really want to. And the people who can't be closed are probably not the people that Botox is going to help you close, because their defects are huge. You're going to have to bridge. So with that as the background, the difference is, and I just want to stress one other quick point is, what scares me about Botox is that you have somebody who isn't comfortable doing very complicated reconstructions, and they think that giving this drug pre-op will allow them to do things that perhaps they don't know how to do. And then you're sitting in the OR, you're in big trouble. And like we are seeing, I'm sure other folks in this call have, we are starting to see folks referred in who got Botox, and then they felt like, oh gosh, we can't operate on them, send them down, 2 weeks after Botox. So I think Botox might decrease some of the physiologic insult of reconstruction, but I think it's a mistake to think that it makes it kind of quote unquote easier certainly for bigger hernias. Smaller hernias, who knows? So,
well, Mike, can I interject just briefly?
Yeah, let's go.
I wanted to add on to that comment because I see a lot out there about using Botox to downstage a component separation. So taking somebody who may have traditionally required a TAR, using Botox to take that person from a transversus release down to just a retrorectus. And I wanted to get maybe your thoughts or maybe the group's thoughts on that, because that's using the Carbonell rectus width defect ratio to predict that people need TARs. Then those people who are, within that ratio, giving Botox to them, and then using Botox as a downstaging. And do you think that is taking somebody who doesn't necessarily know how to do a TAR, using Botox to then put into a smaller operation, and what your thoughts are on that?
Yeah, I mean, I'll weigh in, but others should too. Like, again, this stuff is like unknown. I don't think we have these answers. And, there is in the background, like all the expense and like the kind of logistics of what it takes to make this stuff happen. It's another interventional radiology visit. Usually it's the cost of Botox. And this is a large amount of Botox. So, if you did a study and you showed that that was feasible, then I think it would be interesting. I think kind of my bias is just kind of, and Ben Miller has some data that will come out shortly where we measure all these tensions. I think just always remember, everybody, like why you're doing the actual transversus abdominis release. It's really not to make the anterior fascia come together. So that's not going to change anything. Like Botox isn't going to make the anterior fascia come together and make you downstage a TAR. It might allow, because you got all the lateral muscles to come together, but then you still have this like issue, which it depends on your bias. Are you getting enough coverage of mesh within the rectus muscles? And I mean, like nobody knows that answer. We're all a little different. But if you made the posterior sheath a little more tension free, I think maybe, but man, like you're talking minimum $5,000-$6,000 a hernia now extra.
I mean, I'm not arguing for that. I just thought as an interesting thought. My one just like you pointed out, if you are using the rectus width, the defect width ratio, that typically means your rectus is smaller and your hernia is bigger. And then thus your space for potential overlap of that mesh would be smaller just by definition that you're already self-selecting smaller rectus with the ratio anyways. So I just thought it was interesting about that out there, but
Wait, that just reminded me of something that so this is a common thing. And Kelsi, you even kind of like slightly described it this way. And I think actually, maybe we'll just get this on tape right now. I think this is sometimes what confuses people. And I know this to be true because many people that come in and watch us do this operation, it's one of the first things everybody comments on, is that a TAR is more than just cutting the muscle. It's cutting the muscle and taking the peritoneum far out lateral. It doesn't always have to go to the psoas, but it goes quite a bit more lateral. And so for those of us who do that all the time, we're getting wide coverage of mesh, which is our bias. Again, like unproven, but our bias. And so I think a lot of times people are just cutting the transverse abdominis muscle, and then they don't get that advancement of the posterior sheath. And that's why when they think they're downstaging it, if they just extend it out lateral, you probably wouldn't, you'd be in a safe situation. But if that's all you do, then all of a sudden you're like, wow, I didn't get anything with my TAR. I need extra. So I think sometimes this is like confusion. But again, I mean, like, let me just say, I am conceptually in favor of any drug, device that decreases the complexity of the surgery that is required to fix hernias at a reasonable cost. Like that makes sense to me. Whether it does all that, we got to kind of sort all that stuff out. But if you can downstage, decrease the releases, potentially decrease the size of the mesh, potentially get to no mesh at all, those are all potentially pluses for Botox that should be studied, not accepted, but studied.
And I can jump in and too. There is a study in development, at least, they trying to address exactly that question, Luke. Does using Botox decrease the need for myofascial release? We're trying to see if that's a study we can be involved in. It's an industry funded study. So I do think that's a good question to ask. Very much unproven. There's no data I'm aware of that really suggests that that's the case. The papers presented tonight, most of the literature out there on Botox has high percentage of closure rates, as does almost every other abdominal wall reconstruction literature out there. So other than those exceptions like you guys see and we see and a few other centers that do the really nasty ones, those are the ones that we use Botox on, and it usually doesn't work. So our biases in Greenville is that it doesn't really work, probably because we're picking the patients who it was never going to work on anyway. And the unknown factor of all that is still abdominal wall compliance. We just don't really have a good way preoperatively to predict what the abdominal wall is going to do. Are they going to be stretchy when you get in and start taking down adhesions and releasing layers, or are they going to be stiff no matter what you do? And it's not going to make any difference. And even extensive releases aren't going to help because their physiology is already tainted.
Yeah, we should get on to Sam, but if I would add to one thing, that I think one unquestionable truth in hernia surgery is every mesh, injection, release, whatever technique, when you don't need it, works perfectly and you will feel great about it. And all of those things, when you desperately need it and things aren't coming together and it's not coming together, don't work. Like sometimes you can't win. And I think figuring out who those people are is the art that like you probably never figure out.
And that's why we still do pre-op pneuma, Mike.
Yeah, you guys are just crazy.
Okay, with that, Sam, do you want to take it away?
Yeah, so the first case will be, just to spoil it a little bit, but will be Dr. Rosen doing pre-op pneumo. So let me share my screen here.
This was before I had gray hair. I was thin, healthy. and my shoulders and back didn't hurt.
All right, can you
Might be
guys see
before they
the,
invented the robot, just for the record.
can you guys see the screen?
Yeah.
Okay, perfect. So I'm going to talk about a few cases where adjuncts are used. I have no disclosures. So the first case is that of a 50-year-old gentleman who had gastroschisis. He had 6 abdominal operations as a child, and then subsequently in life developed a CLL, for which he's on Gleevec. He had a predominantly lower abdominal hernia, as you can see here, and recently had a bowel obstruction. So unfortunately, we don't have a CT scan, but what would your overall approach be to this patient? Kind of looking at him and thinking about what that might look like.
Hey, Sam, could I add one thing real quick to your thing? Since we're not on the scan,
Yep.
let me just describe it so people understand what it is. Because this is a very wide fascial defect, probably like 24 centimeters, and he's a fairly thin guy with extremely narrow and wide retracted rectus muscles. And it goes from kind of like just above his umbilicus there, all the way down to his pubis. So he is the kind of loss of domain with wide hernia and the big mushroom cloud sitting outside with, like kind of nasty skin over the top.
Is that IV tubing? Like what is that, Mike?
Well, stay tuned. Don't ruin the like.
What the hell is that? And
This is
I
what
think I
used to
know what
do.
that is.
This is back
What
in the
would you
day.
do next? Nobody can figure it out at all what Mike did next.
What would you do next, Dr. Prabhu?
Well, Samuel, I would probably get a CT scan next.
I just
Before
described
the
it for you. What else
catheter.
you need to know?
Okay, so based on what Mike is describing, can you still hear me?
Yes.
Oh, okay, so sounds like a big hernia. It sounds like a loss of domain situation. And truthfully, I would want to see what the CT scan looks like. Well, he looks thin. I don't know what his BMI is. You share that?
Normal.
He's thin. His BMI is like 23.
Okay, so if that's the case, he's going to have a big loss of domain hernia, and it's not like weight loss is going to get him kind of any improved outcome. So, to answer your question, is there anyone you would consider putting Botox into? Perhaps this patient. I'll be honest with you, preoperative pneumoperitoneum is not something I think is personally safe in my practice. Like, I'd much rather give somebody a bridged repair than like blow them up and have them pop and fly around the room. That might be like a different approach that I wouldn't take for this patient. Clearly that's not what you chose here. But yeah, for me, I'd either do Botox and plan a bridged repair or plan a bridged repair without Botox, but I'd be unlikely to do preoperative pneumoperitoneum.
In our defense, Ajita, we've only popped one.
Did they fly around the room?
Negative.
All right. Any other thoughts or strategies?
Sam, can you just project your presentation?
Oh, is it not up?
No, just like
It's on the you got to hit the.
Okay. Here. Is that better? No.
all good. Keep going.
All right. So, as you can see, a catheter was placed for pre-op pneumoperitoneum. And after a couple weeks of pneumoperitoneum, you can see the abdomen's a little more expanded here. And here is the patient at time of operation. So again, it looks like probably at least maybe 15 centimeter wide hernia. And then interestingly, actually an anterior component separation was done, and that's intraperitoneal stratus. So this is a case, I think, from maybe 2008, 2009. So very different probably than what a lot of people here would do nowadays, but did manage to achieve fascial reapproximation. And, all things considered, a pretty decent cosmetic outcome. And then we have 4-month follow-up here. And that's, as far as I know, the end of the story. I don't know if there's anything else after that happened, Dr. Rosen, but.
Yeah, I mean, to be fair, I don't have long-term follow-up for this guy, but I'm sure he probably has a bit of a bulge, but has not required any more surgery. I think if you back up just a minute, I think, because to be fair, like I think that this is a great example of the learning curve that everybody is going through right now. And to be honest, like everything, everybody forgets what everybody did 15 years ago, and they think they're coming up with something new. And a lot of us just kind of have suffered through learning what to do and what not to do. So like if you go back to his original picture, I wish we had a scan, but it's probably worth like just a discussion of like what I would do differently today, and like what have I learned over the last 15 years. Because one of the things that I think is important for me is like, this is a really big hernia, and he's not the healthiest of guys. One of the things about pre-op pneumo is when you keep these guys in house for 14 days, like you got to keep them on TPA, and you got to keep them on full anticoagulation. They get an ileus, they don't eat well. So you got 14 days of kind of poor health before a major reconstruction. Now he did fine, but to me, I kind of learned my lesson I don't think that's worth it. So today I would have just gone and fixed him, and I would have tried my best with it would have been probably a posterior component separation for me now. And if I couldn't close his fascia, I would have bridged him with synthetic mesh. He would have had a bit of a bulge, and he probably would have been fine, which is probably where he is right now anyways. So for me, that like I moved off of this because I just felt like I was trying to achieve too much in people that couldn't tolerate it. So I know, Jeremy, you guys still do it, but that was like I probably did this like 10 times, and I just at the end felt like, am I really just putting these people through more morbidity than what is safe and right? Especially let me just say, those are for people with the big holes and the big mushroom clouds. It's a little different for people with like inguinoscrotals, where they have it's a small hole. So it's not a hard reconstructive problem, but it's intraperitoneal volume problem. Those, I think, are still more questionable for me. What do you think?
Yeah, I was say, a few things. One, I think we've learned a good bit about the protocol differences. So we certainly don't keep people NPO or do TPN anymore. We actually don't anticoagulate them anymore. We used to actually put filters in all those patients. We've gone away from that completely, probably at least for the last 7 or 8 years, and only do prophylaxis. And they've actually had less issues with VTE compared to when we were, being overly aggressive and putting in filters in people. So we're doing 7 days pre-op and 5 to 7 post-op. So I think we've adjusted that protocol a little bit. But I agree with you on this patient in particular, really wide defects, especially if they have narrow rectus muscles laterally. Like, I don't think you get any stretch with those on a pre-op pneumo. So just like the inguinals, a ventral hernia that's, 8 to 10, 12 centimeters with a big mushroom is a much better hernia to get that volume expansion than a 25 centimeter hernia. So it's about expanding enough to get the viscera back in, not necessarily just advancing the abdominal wall. And we do legitimately do maybe 3 or 5 a year. So
you do an outpatient, you have them inject themselves, you keep them in-house.
We keep them in-house.
Okay. Yeah, listen, truthfully, I think my learning curve for all this stuff is as I became more comfortable kind of fixing hernias, keep people intubated and waiting it out. I moved away from some of these adjuncts. But that's not with like high-powered studies or data. I had I actually had one patient die of clotting her vena cava, probably from being too over aggressive. And that was, to me, that was when I was like, all right, I'm not doing this anymore. Like it was horrible.
So Jeremy, nobody's getting anticoagulation, just prophylactic dosing. How did you come to that and want to take that risk? It seems
Honestly, it was just when I was starting here. So I don't know all of we've looked at our data before, but we had several DVTs, and actually Alfie had a similar patient to what you described, Mike. Complete occlusion of the IVC. It was after a filter was placed though. And we sort of just reevaluated and said, this doesn't seem like the right thing to do. And in theory, we're increasing their abdominal pressure with each of these things, but we're also trying to be aggressive about getting them up and moving around and making sure they get their anticoagulation. And we've not seen any significant VTEs since we made that change, honestly. So, it's a small N, so you can't say that that's necessarily true or just coincidence. But we've gone away from it and have actually not had any issues. It's interesting though, on this case, I think the location would matter too. This being such a low hernia, I also don't think you're going to get much advancement there. And so this is one where you've got that ability to get down into the preperitoneal, kind of retroperitoneal space there, anchor if you go really aggressive, anchor with bone anchors, or even just fixation to Cooper's ligament and things like that. And you get I think that's a different bridge repair than one that's infraumbilical or periumbilical. I don't know what you think, Mike, but
yeah, I mean, I think so. Like this kind of like when I look back at these pictures, I'm like, man, what was I thinking back then? But like I actually, it's so important to kind of acknowledge that, because I often, as I watch people talk about all these adjuncts, I often think back to like they felt like how I did. I mean, this was like 15 years ago when I wasn't as good at ab wall reconstruction as I am today through just time and experience. And I looked at this hernia and was like, man, there is no way I can get this back together. This is so much trouble. Let me throw everything I can at this person. And I think that that's kind of often my message to folks is just focus on getting good at the operation. That will take care of most of this stuff. And then there'll be a few people that need this, but the idea that it's like become a verb of like Botox pre-op pneumo, like, you guys, us, Tony, I think is the same, like in high volume, complex centers, these are rare cases that we think need this. And we don't have like great kind of protocols of who should get it. Like we have good protocol of what to do once you get it. But I think that it just scares me that people are using it to kind of allow them to do things that like it probably just doesn't let you do. And I learned that took me a while. I mean, like I hurt some people along the way, but I kind of realized like you just don't need that stuff.
I don't want to get too off topic, but can I just add, getting Botox approved and actually getting this done is complicated. It's expensive. You have to code for abdominal wall spasticity. And in many insurers, I would say most insurers do not approve it. And I'm not sure what other academic institutions are able to do in terms of admitting somebody and doing it inpatient, but getting someone in the office to get this done by the radiologist, at least in our practice, comes down to patients having good insurance, and not just half good insurance, but Blue Cross insurance. Otherwise, they can't get it.
I think that this is one of the things like where I think people can often speak like very authoritative about how you get paid for this stuff. But I think the reality is to figure out in healthcare whether you actually got paid for something, it's almost impossible. So I can just tell you for us where it's like very restricted, you will not get paid for this. No matter what.
Well, it's not about getting paid. You can't get patients to get it done.
Right.
Their insurance companies aren't going to.
It'll be a no. It'll be a no.
Yeah, exactly.
Now, I think that's different between people who kind of have a system where they bill for it. Like you can bill for all this stuff, but nobody's paying. And so if you do it once a year, no big deal. If you do this 50 times a year, you're going to set off alarms. So I think, you know, there needs to be data to support it to get this approved. I don't blame insurance companies for pushing back hard on this. But yeah, I mean, for us, there's no way that we could schedule somebody to go to radiology and do this outside of a protocol. I've done it. I did it once when I came over here. Like the only chance we could have to do it would be to take the patient to the operating room and like, say you're doing a diagnostic laparoscopy or something, and like, you can get anything you want in the operating room once you're there. So that's about your only shot. But scheduling this for us, no chance. I don't know. Jeremy, is that true for you guys?
We don't do it much, but we've got one of our IR guys has kind of got his system down for getting patients in and evaluated and done. So the times that we've tried to do it, we've been successful. We just haven't found that much need for it, honestly. So stay tuned if we're able to do this trial.
The key for approval is the word spasticity. If Botox is indicated for spasticity all over the body, so as long as the diagnosis is abdominal wall spasticity, usually you can get it approved.
And that may be what he's doing. I honestly don't know the answer to that.
Yeah, it's probably worth taking a pause at this moment too and just saying, hey, look, the bucket's this big. They just changed all the coding for hernia repairs to rein it in. And that's just the first shot over the bow. So, you know, we're only getting so much money for what we do, and we should think about where we want to spend it. Otherwise, the books are going to be balanced at the end of Medicare, like in insurance companies, they will balance the books. So if this stuff is worth it, we should fight like hell for it. And if it's not, we should move on. Sam, you got one more case? It's getting late. Let's try and get through one more.
Yep. So second case is a 70-year-old gentleman who underwent colostomy reversal and attempted ventral hernia repair at another institution. It sounds like they encountered quite a few difficulties. They ended up closing the posterior sheath with vicryl mesh, used biologic mesh in the retrorectus space. The anterior fascia would not come together. And so they also combined that with an external oblique release, leading to avulsion of the left rectus muscle. And then the patient also had wound morbidity issues, including wound necrosis, infection, ended up with a wound vac, and then a split thickness skin graft. His BMI is 36, and he happens to be a smoker. So here's how the hernia looks externally, and then the CT scan here. So Megan, as you look through this, like what things jump out at you? Try to speed this up just a little bit here.
What jumps out at me is why you have all those squares on your PowerPoint, Sam.
Oh yeah, you know, I don't know.
Now that's okay. If you go to the presentation mode, they'll go away.
Yeah,
that's
it
what
just
Megan was trying to save you.
Can you see this without like
fair.
notes
That's
and
fair.
stuff? All right.
You're in presenter view, but that's okay.
Is this actually going here?
Oh, is it not going to play now?
Here. Okay. So what jumps out at you?
Is that a loop of bowel up in that mushroom in the top of the hernia sector? Can you
Like patient right?
go back
Yeah.
up onto the top?
Yeah.
Mid hernia, is that a really dilated loop of colon?
Yeah, I'm looking more like you can see laterally. It looks like they've probably
No, semilunar injuries.
gotten into the wrong plane bilaterally, and then you know you can kind of appreciate that the soft tissue is pretty widely spaced here on both sides.
Widely spaced and fixed. Yeah.
Yeah. So going to the next slide. So what would the group's approach to this type of patient be, or what types of things would you be thinking about?
We can see it on your next slide.
Oh, you can see it already? Oh, okay.
All right.
All right. So this patient underwent stage tissue expansion. So they had tissue expanders placed about 3 months before their hernia repair. Placed 17 by 8 by 8 centimeters bilaterally, and then they were expanded over the course of 3 visits. to about 1 liter in volume over time. Here you can see, I was trying to exclude them from the original picture there.
So
but
where were those expanders placed exactly, in the sub-Q?
Sub-Q, yeah.
So if you go back real quick, just in the sake of time, let me just, I think one of the things about this case that is challenging in all hernia repairs, and when you think about adjuncts, you're likely gonna have a soft tissue coverage issue. And I'm sure that the kind of the goal here was to try and use synthetic mesh since it's a big hernia.
Mhm.
And when you're in soft tissue issues, then you have the potential to raise flaps to get it closed. But if that's not enough, you're in big trouble. You can bring a remote flap, or they can expand. And just a little bit about expanders when you should call plastics. In order to expand somebody appropriately, the expander must be over bony prominences. That's why they put such a big one in. If you just put them kind of in the central abdomen, then all it does is it just pushes into the abdomen and it doesn't actually stretch the skin. So they'll always want to be on the costa margin and iliac crest to push out and get you appropriate expansion. And then that's why I asked you where they were. When I was over at UH, they like to put them in the sub-Q. Some of our plastic surgeons here prefer to put them in the kind of below the external oblique, because they can do an anterior components in these cases, because you have to raise the skin flap anyways. But I never find that like actually stretches the skin like a sub-Q one does. But another thing, just since we kind of beat on Botox for cost, these expanders are extremely expensive because they all have to be custom made based on a plastic surgeon's measurement. So this is also a very expensive adjunct to do. And if you need it, you need it. But always something to think about when you're thinking about cost-effective ways to deal with it.
All right, thank you. So patient had very extensive adhesions once they finally got to the OR. There was an enterotomy that was made. They had a 24 centimeter wide by 30 centimeter long defect. Bilateral tar was used. Again, bicral mesh bridging of the posterior sheath was needed. And then the patient ultimately had a bridged repair with 50 by 50 centimeter medium weight mesh. The mesh was fixated around the periphery with transfascial sutures, and then the skin was closed with nylons. 1 month post-op, the patient actually, did okay. Of course, it's complicated by ileus, had some serous discharge from a skin dehiscence superiorly, but otherwise, didn't have any major issues. And then followed up at 1 and 2 years without any imaging or exam evidence of recurrence. So, a short-term win. Unfortunately, about 5 years later, the patient had started to smoke again, had a bulge and recurrence on exam, and then had 3 small bowel obstructions in the month prior to presenting back to clinic. Was felt to have a mesh fracture. It's since been reoperated on. I think just my takeaway from this case would be, I think adjuncts can be helpful in very select cases, but I think this case and some other ones we talked about really highlight the importance of talking about the, complications of repairing these hernias in general. Noting that bulge and contour might not always be 100% normal, and that long-term, the chance of recurrence is probably higher than, what we have often presented in literature, at least.
So just out of curiosity, like since we got all this stuff, Kelsi showed us, Sam, do you think that patient should have got Botox beforehand?
Probably, I don't think so. I mean, I've literally never seen anyone get Botox, so it's hard for me to say that they should. I think it was kind of an intra-op decision that was made to not try to force it, and I've seen it go the other way, where people have been closed really, really tight, and in rare cases have had issues. So I think I think we've learned a little bit more about mesh weight and importance of that as it relates to bridge repairs would be one thing I might do differently.
Tony,
Even
would you guys have Botox that guy beforehand?
Who are you talking to, Mike?
You, would you have Botox in?
Boy, I don't, that's a really tough one. I might have thought about it. It would have not gotten approved. And like you said, maybe at the time of closing, I would have considered putting Botox in the hopes that it helped mitigate some pulmonary problem the next week or two. But keeping the patient intubated afterwards, I would have done that. Probably intubated and paralyzed for a day or two. The sad thing about that case is the index operation, the semilunar injury, just made things just horrible. Like what a terrible case.
Well, yeah, I mean, I think one of the things we're learning about is this story never ends. And, you know, even though we do Atari, put a big piece of mesh in there, these meshes are breaking. We have some more data coming out soon. Any company that's listening, there is a need for a heavyweight, larger piece of mesh than 30 by 30. For those of us who do this a lot, that is an unmet need in hernia surgery. We're learning the hard way that, you know, medium weight has its limits, and you can only ask it to do so much. So just throwing that out there to the Ethernet. All right, well, it's getting late. Why don't we wrap it up? Megan, you kind of conclude things, but just thanks to everybody and great conversation.
Yeah, thank you, Sam. Thank you, Kelsi, and thank you, Dr. Iacco. Great discussion as always. Next month, we're on December 12th, and we're going to be discussing MIS ventral hernia repair laparoscopic approaches. Moderator is going to be Dr. Rana Higgins. I'm going to present as well as one of our residents. So thank you guys, and I'll see you next month.
Oh, one last announcement. Don't forget QI Summit coming up in March, first week in March. You should have gotten emails for it. We got a great agenda, a lot of good data, a lot of interactive sessions. So please put that on your calendar and look forward to seeing you guys there. Great job, everybody.
Thank you, everybody.
Thank you.